Thanks, Susan, and welcome everyone. So today we have the privilege of hearing Natalie Dayan tell us about her research. She's an associate professor here at McGill, a member of CORE, member of CHAL. She is the director of the Obstetric Medicine Service, and she's won several awards, including her work was supported by Foundation de Recherche en Santé au Québec, chercheur boursier Junior 2, also an early career professorship in women's heart and brain health by the Heart and Stroke Foundation of Canada, as well as funding from McGill and from CIHR. So take it away, Natalie.
Great. Thanks so much for the invitation to present to you today. So I'll be discussing about my work looking at big data analysis of health outcomes and health service use in women after surviving severe maternal morbidity in pregnancy. So as mentioned, I have received operating funds from CIHR Heart and Stroke and a speaking honoraria from HTAC Biomedical, but I don't believe this poses any conflict of interest. And I want to acknowledge and thank Melia Alcantara, who is a former master's student working with me for sharing some of her slides today. So for today's talk, I'll be reviewing trends and the definitions of this composite outcome that we use a lot in maternal health research and obstetrics research, severe maternal morbidity, using administrative data. I'll be presenting data on long-term health after severe maternal morbidity, and then an approach to considering the effect of repeat adverse pregnancy outcomes on long-term health. So how to model the exposure to a pregnancy event, knowing that a woman will have future pregnancies or not, and how to sort of account for that in analyses. So first of all, maternal health is an international priority. And I'm showing you a slide from the UN Millennial Development Goals 2015 report on global maternal mortality. So that's the maternal mortality ratio is usually expressed as deaths per 100,000 live births, and globally, it has been in a level that is well above what we experience in Canada, and there has been progress made towards the goals of reducing maternal mortality from, as you can see, 380 deaths per 100,000 overall to 210 deaths per 100,000 overall in 2013. So it has declined pretty much everywhere. And in Southern Asia, it has declined by 64%. And there's been an increase in the proportion of skilled health personnel that are attending to births, which which is likely a trend that influences the reduction in maternal mortality. So we have a ways to go, but there has been improvement there. And so maternal health is an international priority. In terms of maternal mortality, looking at the maternal mortality ratios, again, per 100,000 births in high resource countries, or now what we would call the global north, in 1980 and 2008. So comparing sort of several decades apart. As you can see, there have been improvements in many countries such as Germany and France. The US is notable for a worsening, and that is a trend that has been concerning for our neighbors. And in Canada, we've pretty much been stable at that 5 to 10 per 100,000 births for quite a long time, and we're still around that mark. You may be familiar with the March of Dimes, which was initiative in the 1960s and 70s led by Franklin Roosevelt to really look at what is happening with maternal health and maternal mortality and neonatal mortality, and essentially implementing a different levels of hospital systems with regards to maternity care and mostly neonatal care. And this improved dramatically, as you will see some of the perinatal markers of quality indicators rather. So neonatal mortality has improved substantially since that time. So you can see that neonatal and infant mortality or post-neonatal mortality are expressed differently. So neonatal being in the first 30 days of life reduced quite substantially from 1960 until the early 2000s. Similarly, but to a lesser extent, the post-neonatal period, so beyond 30 days, infant mortality has also improved. And so has maternal mortality rates, and this is US data, but as you can see, there was an uptick which increased even beyond this period. So while we can say that there's definitely been a dramatic improvement, there are still areas for improvement in the US. So within Canada, these are the maternal health indicators that the Public Health Agency of Canada and the Canadian Perinatal Surveillance System endorse. And they are maternal readmission after childbirth, induced abortions, ectopic pregnancies, maternal mortality, and severe maternal morbidity, which I have here in bold font. Canada, like some of those other global north countries, as I showed you, the maternal mortality rates are so low that it's difficult to implement any quality improvement indicators at the population level to impact on maternal mortality since it is so rare. However, severe maternal morbidity is orders of magnitude more common and has increasingly become a focus of public health research and surveillance. So how do we define severe maternal morbidity? The WHO definition is actually a very ill pregnant or recently delivered woman who would have died had it not been that luck and good care was on her side. And that's really, that really encompasses what we know about it. It is essentially a near miss complication that usually occurs around the time of childbirth, but can be during pregnancy or within 42 days after birth. Historically, this was the concept and the definition was a Delphi review of near miss cases, so more of an inquiry or an M&M sort of case review by experts. And then the definition has evolved over time to becoming more of a, or there are those who still advocate for a more of a disease-based approach. So basically combining, again, using expert consensus, a number of disease states that are so severe that they would typically cause serious illness that could very possibly lead to death if not for good care and luck. Eclampsia, stroke, uterine rupture being examples. Procedure-based is another approach that has typically been used as a way to define this in studies and in surveillance programs, and also end organ failure. So each of these have their strengths and limitations, as you can imagine, and increasingly a combination of these different codes and approaches is used. And at the bottom of this slide, you'll see a figure depicting really why should we be focusing on severe maternal morbidity and how does it relate to the severity of illness that can be seen in maternal populations. So obviously the worst outcome is a maternal death. But its upstream counterpart, severe maternal morbidity, is now what we really need to be focusing on. The trouble with severe maternal morbidity and death, as well as the early warning sign, is that in obstetrics, catastrophic complications occur very, very rapidly. So the more upstream you could implement any preventative strategies, the better off the mother and child will be. So essentially, because we've done such a good job in Canada, we are now shifting our focus backwards to preventing severe maternal morbidity, which really means looking at early warning systems and looking at managing chronic or pregnancy-related conditions. So in Canada, the definition has been developed by the Canadian Perinatal Surveillance System, and there have been a couple of iterations of this definition. It's a validated combination of codes using the CHI-HIDAD and procedure codes, so about 47 diagnostic codes, 47 procedure codes and about 70 diagnostic codes. And it's a combination of disease, procedure, and organ-based approach. It was originally developed by K.S. Joseph out of BC and a number of colleagues on the Canadian Perinatal Surveillance System, in which there was an expert review and consensus of list of SMM indicators, so diagnoses and procedures. And then these were further validated against case fatality in that something had to be strongly associated with mortality if it were to be included as a severe maternal morbidity indicator, as well as prolonged hospital stay. So as you can see, the codes that ended up being on this list had high case fatality rates compared with pregnancies that did not have any of these indicators, and similarly for prolonged hospital stay beyond 7 days. And the vast majority of deliveries are discharged after 24 hours, so 7 days is quite a long period of time to be in hospital, indicating morbidity. So trends in Canada in terms of, again, per thousand, typically expressed per thousand. So as you can see, it's been somewhere on the order of 15 to 20 per thousand, overall 16 per thousand. This does vary by province, but I'm not showing you that data here, and has gone down somewhat over time. And this surveillance up until 2016. However, some indicators such as hemorrhage have actually seem to have certain trends that indicate increase in some years. Other indicators that are worthwhile looking at are things like assisted ventilation. And this is, again, pre-COVID era, so indicating possibly some cardiac or pulmonary conditions. So I'm going to shift now into what do we do after a woman survives or has a severe maternal morbidity event, thankfully does not die, and survives to hospital discharge. Typically, this would be a cause for celebration for healthcare providers. You have potentially saved a woman's life, a pregnant woman's life, and hopefully the baby as well. And then they are discharged home. So historically, there has not been an effort to evaluate outcomes after these critical care events. And this is an area that's been increasingly studied and an area that's of interest to me. So those who do survive may have either underlying chronic diseases that were not identified prior to pregnancy. And when we look at conditions, pregnancy-specific conditions like eclampsia, we know that there are a lot of pre-existing health factors that really increase the risk of preeclampsia and eclampsia and those hypertensive disorders of pregnancy. And oftentimes we do identify those with chronic diseases or chronic disease risk factors. There also may be residual organ dysfunction. So there's definitely evidence to suggest that there's accelerated vascular impairment and endothelial dysfunction following some pregnancy complications, such as, again, the hypertensive disorders or even obstetric hemorrhage. There could be new chronic disease that arises in pregnancy. We do know that pregnancy is a relative immune tolerant state, and the autoimmune diseases can flare in the postpartum period or develop de novo. There can be from a mental health perspective, and there's I'll share with you some information that we have from our patient partners about the impact on mental health and post-traumatic stress after surviving a near-miss event. as well as physical disability, and then poor social determinants of health. Again, this could be a factor that would have increased the risk of the maternal morbidity in the first place. So there are definitely some major gaps in postpartum care and a number of missed opportunities for health improvement. So it's really important to be not only looking at health outcomes, but what are the needs and the health service utilization needs for this population. So in terms of what happens after the postpartum period, Ugochi Vivian Yuka, who is a former postdoctoral trainee working with myself and Robert Platt, and who now works in the States, did a population-based study using Quebec administrative health data in collaboration with Natalie Dayan at the INSPQ. And we looked at 1.2 million births from 1989 until 2016, looking at exactly this question. So among those who had a severe maternal morbidity in their last pregnancy, or if they only had one pregnancy, in their only pregnancy, looking at the impact of having a severe maternal morbidity on all-cause mortality or cause-specific mortality in hospital beyond the postpartum period, which is typically defined as 42 days, but can be extended to the 1 year postpartum. And so they were followed for the duration of the study. And as you can see here, that having any severe maternal morbidity at any point, the mortality rate per 1,000 person years was calculated to be 0.86 and was about twofold higher than those who had no severe maternal morbidity in the entire follow-up. And the Cox regression analysis was used for this. And so you can see the rate among those with no morbidity was 0.41. Then if you look at some of the specific severe maternal morbidity indicators, such as severe preeclampsia or eclampsia, severe hemorrhage or cardiac complications, you can see that clearly the type of morbidity that was experienced in pregnancy influences mortality beyond the postpartum period. So cardiac, stroke, renal failure being examples of those that have quite high rates and adjusted risks of mortality. Clearly this dissipates with time. So indicating that, the arbitrary cutoff of 42 days is exactly that. It's an arbitrary cutoff. And clearly there are, some disease processes really do continue beyond the 42-day period. And as you go from the 10 to 29 year period, the risk is much more dampened, but still present, indicating, again, those factors that either there are unidentified chronic diseases or there's some development of new chronic disease or risk factors for premature mortality in these individuals. So to me, all this says is that, these are individuals that require surveillance, that require good healthcare beyond pregnancy. And we really need to be looking at that postpartum period as a window of opportunity to influence their health trajectories. So this leads me to the Beyond Survival proposal that the series of studies that we are undertaking now to examine the health of mothers and beyond the health of mothers who have survived a severe maternal morbidity event. And so what we are doing is that we are looking at this in a number of different Canadian data sets. The CIHI Canada-wide data set excluding Quebec. We're also looking at Quebec-specific data, and we're looking at population data within British Columbia so that we could answer some of these questions, which are, what does severe maternal morbidity and any of the severe maternal morbidity indicators, namely preeclampsia, hemorrhagic, cardiovascular, et cetera, how do these lead to long-term health outcomes? What are the healthcare utilization patterns that we could identify, are there an increasing or decreased family physicians for patients who have poor health outcomes? Are there increased specialist visits indicating that there's chronic disease development? Emergency room visits or hospitalizations suggesting severe uncontrolled disease. And then again, what are some of the health outcomes and some of the determinants of those health outcomes? While we were developing these set of studies, we met with a group of we met with the leaders of this 1,000-person group called Maternal Near Miss Survivors. It's a patient group in Canada and the US. And we had a number of different discussions with them outlining what matters most. It really seemed that what matters most to these individuals are, can they reproduce again? What is their next pregnancy going to look like? And their mental health was clearly a priority. In particular, a lot of trauma, a lot of worry about what their symptoms are, hypervigilance, and some indication that emergency department visits may be a reflection of patients not being hooked into the healthcare system and not knowing what is normal and what is abnormal after they have a near miss complication, in addition to, of course, actual physical symptoms and physical well-being. So with that in mind, we developed these study aims, which are within Canada and Quebec, to estimate rates and risks of future obstetric and non-obstetric all-cause and cause-specific hospitalizations after first affected severe maternal morbidity pregnancy. And then in British Columbia, because there is robust outpatient data as well as allied health professional data, and GP data to be able to describe healthcare utilization patterns after severe maternal morbidity. And and again, in the British Columbia data set, to be able to estimate the prevalence of non-communicable diseases, such as mental health, cardiovascular diseases, and other diseases after surviving severe maternal morbidity. So this is the team, which is a team from McGill, Université de Montréal, Ottawa, UBC, and Toronto, and fantastic students, and as well as a research team, Jessica and Gabriel, so all of whom contributed to this proposal. And so I'll share with you what we have, some of our preliminary data. We have started with looking at recurrent severe maternal morbidity, sort of prioritizing those areas that were important to the patients, looking at their reproductive outcomes. So we did this using the Quebec data, in which we looked at just over 800,000 people who have had at least 2 pregnancies in Quebec from 1989 up until 2021, so a contemporary cohort. We excluded those who died who had a hysterectomy or tubal ligation at first birth or between the first and second birth, those with twin gestations or with missing identifying information. And then we essentially, using the CPSS definition of severe maternal morbidity, so that combination of ICD codes and procedure codes, we identified an exposure to severe maternal morbidity or not in their first birth, and then followed them until their second birth for severe maternal morbidity and no morbidity. We then were able to look at the subtype, again, using validated combinations of codes, so cardiovascular / preeclampsia, hemorrhagic, sepsis, and other. And we performed a log binomial regression, looking at the rate and risk of a repeat or de novo complication, adjusting for factors at the first birth, such as age, comorbid conditions, substance use, socioeconomic deprivation, and time period. So these are the baseline characteristics according to whether or not individuals had severe maternal morbidity or not in their first delivery. So what's notable is clearly those who had severe maternal morbidity also had a greater proportion of them had a comorbid health condition. Also, more of them were had socioeconomic deprivation, 22% versus 19%. And so those are some notable differences there. And what we were able to show is that among those who had severe maternal morbidity in their first delivery, the rate of recurrence was 65 per 1,000 in the second delivery, with an adjusted risk ratio of 3. That was statistically significant, as you can see, and the cardiac complication was clearly one that was a subtype that was strongly associated with a recurrence. So some subtypes, as you can see here, were more strongly associated with a recurrence, but essentially any morbidity was associated with a recurrence compared to those who did not have a morbidity in the first pregnancy. And if you look at things like the number of morbidities in the first pregnancy, so somebody who would have just had a code for HELLP syndrome, but otherwise no other diagnostic code indicating severe maternal morbidity, would be coded as having 1 morbidity. And those people still had a higher risk of recurrence in a second delivery. But the more indicators you have, clearly the sicker a person was and had a higher risk of recurrence in the next pregnancy. We did look at whether the recurrence was a concordant or discordant. That is, if you had a cardiac complication, were you going to simply have another cardiac complication in the next pregnancy? And yes, that was, so in blue, you can see those are the concordant severe maternal morbidities that occurred in the next birth, compared with discordant. So what's interesting is that there still were discordant morbidities, and there was sort of an overlap, or for example, those who have obstetric hemorrhage were still more likely to have some other morbidity. Those who had a cardiac complication, even though we're more likely to have a cardiac complication the next time, could also have another complication, such as hemorrhage or such as acute renal failure. So that was an interesting finding that was not that essentially has not been found in previous work. In the US, there are 3 existing cohorts that have tried to look at severe maternal morbidity, similar rates to us, smaller sample sizes in most cases with inability to look at subtypes. So, so that was a novel finding. So we are now starting on the Beyond Canada-wide cohort. And that's where we are going to be looking at all-cause and cause-specific hospitalizations, both obstetric and non-obstetric, but focusing on the non-obstetric hospitalizations that would occur Canada-wide. And again, in keeping with the patient-oriented outcomes, the first outcome that we will be examining will be severe mental illness requiring hospitalization or an emergency department visit. So we're just in the process of developing the cohort of essentially 2.5 million index pregnancies. We are excluding therapeutic abortions and ectopic pregnancies, and are including those with an age range in the 18 to 55 range. And we do have some descriptive statistics to share for this cohort in terms of the overall age of the cohort, which is about 30, and that's what we know to be the case for first births in Canada. Income, urban or rural residence, the length of gestation, which is generally speaking term, the proportion with preterm, and then the year range that the individual delivered, as well as province. So you can see that here, Ontario and British Columbia, as well as Alberta, have contribute the most deliveries, with the exception of Quebec that is not included in the CHI data source. So we're looking at the first pregnancy for each member of the cohort during the study period. And we can discuss that, and I'd be interested to hear your thoughts on the different approaches to examining an exposure to a pregnancy event and long-term health outcomes. There are many different ways to do this, but we decided to look at first births that are either affected by severe maternal morbidity or not. And we will be censoring on death and next pregnancy or the outcome or the end of the study follow-up. So what we're able to see that in first births, there has been a slow but steady increase in severe maternal morbidity in first births. This is more contemporary than the surveillance data that I showed to you earlier. And also the numbers are a little bit higher, but remember that these are all first births, and people who have first births are more at risk of a variety of complications than overall births. So that is another possible explanation why the rates are slightly higher than what has been reported in the Canadian surveillance data that was up until 2016, in which it was more closer to just under 20 per 1,000. So I now would like to shift over to how should we be modeling the effect of recurrent severe maternal morbidity. Is there a cumulative effect of multiple pregnancies that are complicated by a severe maternal morbidity event? And this is a question that arises each time we design the study. And I'm very excited by this new project that we are undertaking along with Mikhail Abrahamovich and his team. So the question is, what is the association between severe maternal morbidity and one of the cardiometabolic outcomes that I mentioned, which is cardiovascular hospitalization? So previous work by our team and others have shown that there's an association between severe maternal morbidity and cardiovascular hospitalization, but it's highest within 1 year, although it persists to some degree up to 30 years after birth. Typically, it has been modeled as a simple time-varying exposure where the mother is unexposed until she experiences a severe maternal morbidity and then exposed after that, or as mentioned, you can simply select just first births and assess whether somebody is exposed or not to a first birth. But it's unclear whether this is the optimal way to be modeling severe maternal morbidity exposure in people who clearly have more than one birth over a time period and over the course of their life. So the possible patterns of exposure would be that there is a blip, an SMM event occurs, and then there's sort of an increase in your risk of an adverse outcome, but it plateaus thereafter. So there's simply just, you can describe this as an increased risk at one time period. And it's reasonable to just sort of estimate it in as a dichotomous outcome. Or it could be, as we've described, that over time, the risk dissipates. So you have an event, and then there is a blip. You have an increased risk of some adverse health event after your exposure to a pregnancy complication, but that this goes down gradually with time, or some other pattern. Moreover, it could be that, and we know this with other pregnancy conditions, so those who have had recurrent preeclampsia have a much higher risk of cardiovascular disease than someone who's had it only once in their first pregnancy. So having recurrent events, there's a cumulative effect of repeated pregnancy adverse outcomes on the future health of that person. Or, as I mentioned, the more severe your severe maternal morbidity, that's kind of a mouthful, but in essence, no two complications are the same, or outcomes are the same necessarily. So someone who was in the ICU for a month on mechanical ventilation is different than someone who had transfusions of red blood cells for postpartum hemorrhage and perhaps uterine artery embolization. So clearly, the more indicators you have, the sicker you are. That also might increase the risk of an adverse health outcome. So there are a number of different patterns of exposure that are challenging to model through simple epidemiologic designs. So a few years ago, actually, this was pre-COVID when we were getting together in person, I attended McGill's wonderful talk on weighted cumulative exposure, looking at drugs in administrative databases and the cumulative effect of drugs over time, taking into account dose, duration, timing, etc. And so the effect of a drug is not the same if it was taken 10 years ago or 15 years ago and at a low dose than it is if someone's taking it now at higher doses, for example. So I wondered at the time, and McGill and I spoke, I don't know if McGill is here today, but I wondered at the time, can we do this with pregnancy events? So if we're looking at how someone's health trajectory is impacted by pregnancy events, can we be modeling, can we be using this approach in administrative data? So this is a project that we're undertaking with the same data source, in which we are considering the severity of the severe maternal morbidity, the timing or the interval, as well as so the dose, the duration, and the timing, and whether it's been repeated over time. So essentially, this is the equation in which we have the time of the cardiovascular event, and of course the severe maternal morbidity occurs before that, and usually again by at least 3 months prior to the cardiovascular hospitalization. Some would argue that it should be even longer before. That we would be looking at the intensity of the event, i.e., so this requires a bit of subjectivity, but looking at the severity, looking at so the actual diagnoses and how many indicators, et cetera. And then the weight function would then incorporate that, as well as the whether or not it has repeated over time. So we are going to be looking at that in the CHI data source and be assessing whether this is an appropriate way to examine and pregnancy exposure on a long-term health outcome. So in summary, I hope I've conveyed that severe maternal morbidity is an important public health metric, is closely related to mortality on the spectrum of health in a pregnant woman's experience. We should not assume that people are necessarily well after surviving a severe maternal morbidity hospital discharge. That is definitely cause for celebration, as the alternative is much worse, but this is a window of opportunity that we do need to examine a bit more closely. Pregnancy events and long-term health is now an increasing focus of research, which I think is really fantastic. And how to model recurrent pregnancy events is a matter of ongoing debate. And I'm excited to be looking at whether weighted cumulative exposure is one possible approach. So with that, I thank you for your attention, and I'm happy to hear any questions or comments from this group in particular. As we are designing the Beyond study, it would be great to hear your thoughts.
Thanks, Natalie. That was very, very cool. I really liked that talk, and I really like the discussion about best ways to approach this sort of methodologically. So I did have to step out briefly to deal with some things, but I'll start with comments from the chat. Sasha has some comments. If she can unmute, you're welcome to ask your question yourself, Sasha, or I can read it out. So maybe I'll read it out. So she's commenting that increased rates of severe maternal morbidity over time. Is it possible that some of that is related to shift in maternal age at first pregnancy? Also, if the increasing prevalence of obesity or diabetes might drive some of the sort of secular trends in the increased rates of severe maternal morbidity over time.
Thank you, Sasha. Great question. And absolutely, there's other work that has definitely shown that maternal age and comorbidity, as well as obesity, are determinants of severe maternal morbidity, and likely do underlie some of these trends. I would have to say that the average age at first birth has been about 30 now for some time. So it's probably not, at least for any recent increase, it probably wouldn't strictly be age. But that being said, age and associated comorbid conditions, as well as use of assisted reproduction, are some of the factors that are at play here.
Okay. Sasha also asks about how you might deal with missing data, covariable data in the admin, especially smoking.
Yeah, so we'll be approaching it similar to other administrative approaches. So we'll probably be using multiple imputation type of strategies, and but it will depend on the variables that have missingness. Unfortunately, certain variables like smoking that will be missing or misclassified for sure. That is definitely an issue, which is why in the CIHI Canada-wide data set, what we're hoping to achieve is to really have that bird's eye view of all-cause hospitalization and cause-specific hospitalization. So starting with mental health-related hospitalizations, without really necessarily being able to tease out any mediation of these associations or trends.
Okay, so I'll ask a question. It's okay. So I was kind of floored actually by, at the beginning of your talk, of the definition of severe maternal morbidity, like that the definition that you had in a box, in how sort of non-specific and almost non-scientific it was in terms of the term luck appeared. And then even in some of the alternate definitions, yeah, it seemed like it was all over the place, like near misses. I mean, I'm not sure if that's necessarily morbidity, but it's important for sure. But it just sounded like, whoa, there's so much progress to be made in this space. So I'm super glad you're taking it on. I was also struck by a lot of the data you showed kind of like time series type data ended around 2010. So is there a lack of data in the 2010s, or everything looks good and so you don't want to highlight that? Or like, I was surprised.
No, so 2016, the latest published surveillance data is 2016, and there's another set of surveillance that will be published soon.
Okay.
So it's just that it doesn't get published every year, unfortunately. But in terms of your first question about the definition, so the Canadian definition actually is more scientific, and it's basically a severe event that is strongly associated with death that occurs around the time of delivery or within 42 days postpartum. And that's pretty standard. The CDC has a very similar definition. It's more, the definition I shared more reflected the concept of this definition over time. But this is definitely an issue. So when comparing countries, for example, looking at you can easily compare maternal mortality. I should say it's not necessarily easy because different countries have different inquiry systems or different reporting systems for death and maternal death. But that being said, death is death. And if you trust the reporting system, you can compare maternal mortality ratios from one country to another. It's challenging, however, at this stage to be comparing severe maternal morbidity across different countries. Increasingly, US definitions and Canadian definitions are getting closer to each other. And there is momentum in not only harmonizing the definition, but also making it as like closer to the truth, the real morbid person who would have who really would have died. I think the Canadian approach was a good one, validating these set of codes against mortality and length of stay. So I think that's a good start. And but it is definitely it's evolving. In fact, Isabelle Malhamé is doing really awesome work at an attempt to have a confidential inquiry system throughout Canada. So sort of a chart review system to validate the administrative or complement the administrative definitions.
Cool.
I hope that answered your question a little.
So
Sorry,
really
go ahead,
nice work, Natalie. It's fun to look at how you're approaching the analyses and especially the methodological work. And I think one of the challenges, that we're also confronting in some of the work that we're doing is if you have a pregnancy, well, especially with what you're doing, if you have a pregnancy with a big morbid event, your likelihood of deciding to become pregnant again is probably related to your risk a bit of the future event. So I still haven't really figured out, how one deals with that. You could say, okay, I acknowledge, like we often do, we'll say, well, we acknowledge this is a lower risk population than it would be otherwise if everybody had equal desire to get pregnant. So maybe you can think about that in your methodological work. Like I've heard of models, there's this double hurdle regression, because the first point is you have the event, then what is your likelihood of getting pregnant again? Yes or no? And then it's, if you're pregnant, what's the likelihood of having another bad event? So have you guys discussed that a little bit?
Oh my gosh, yes, we've discussed it a lot. And it's I have a lot of fun discussing it, I have to say, but we never end up at a solution, because the issue with the likelihood of another pregnancy is that there is choice in there. So it's not just the likelihood of pregnancy, that's presuming everybody truly wants to become pregnant again.
Exactly. The choice.
So because there is choice too, and people can choose to have 1 child, 2 children, 3 children, so they can choose to, and then even if they do choose, they either can become pregnant or not pregnant. So that's really challenging to look at from an administrative, using administrative data. I think you would need a carefully constructed prospective cohort of all reproductive age people, then follow them over time to really and ask them the questions about intentionality. Do you intend to conceive? And a lot of times also they might be advised not to conceive again. So they might be advised not to conceive again. They may choose not to conceive again. They may have a rupture in their partnership or what have you. So there's so many factors that I think that piece is quite challenging to get at in existing big data. This is why for our recurrent severe maternal morbidity paper, we decided to restrict to those who had 2 pregnancies, understanding that
we've done something
we are
similar.
not, that we're not commenting on, and those people who can't reproduce again, they have different needs. I'm just not able to really assess them.
No, it's good. The other thing you can do is if you can figure out, depending on your outcome, what from the literature, if you can figure out the smoking rates and sort of associations with the outcomes, there are ways of adjusting your estimates. You don't have the data, obviously, to directly do it, but you could do some adjustments after you calculate your estimates. So I can send you some of that.
Oh yeah, that's a great bias analysis suggestion. Thank you. Yeah.
Good.
Thanks so much.
Sasha had a question. So she asks, is there a role for aspirin in certain settings? It would be related to first pregnancy complicated by eclampsia. Then do they get aspirin? And can you tell from admin data, or are they getting aspirin over the counter?
That's a great question. We would be able to look at this in some data sets, but not others. This is why in CHI, in the Canada-wide study, I'm going hesitant to look at disease-specific outcomes. We could look at hospitalization with a given disease, but not disease-specific outcomes because of exactly this, the missing covariates and the lack of outpatient data. But absolutely, the use of certain medications, in a way, this isn't a great thing, but for research, it sort of is that that's all we really have is aspirin to prevent morbidity in pregnancy, aspirin and calcium and sometimes low molecular weight heparin. But essentially, there aren't many drugs that are used to prevent these pregnancy complications. Aspirin is one of them, though, for sure. That would be important to look at least for preeclampsia. Thanks.
Great. Thanks a lot. I have other questions, but maybe I'll catch you in the corridor of core to ask them to you. So thanks so much for the talk. Thanks everyone for attending. Hope you all have a great evening.
Thanks. Have a good evening, everyone.
Ciao.
Bye.